Okay, again, thank you everyone and welcome to this virtual meeting speaker presentation of the National Capital Area Chapter of the Depression and Bipolar Support Alliance. And this day we've scheduled a talk on alcohol and substance use in bipolar disorder, importance, implications, treatment. Our speaker is Dr. Nefize, and correct me if I'm mispronouncing it. Nefize
Yes.
Yalin.
Yes, that's correct.
Of the National Institute of Mental Health. And we are being recorded, by the way, please note, and this recording will later be made available. And I should say, and again, I apologize for any mispronunciation, the basics about Dr. Yalin. She graduated from the School of Medicine of Ege University in Turkey, completed her training in adult psychiatry and a PhD in Basic Neuroscience in the School of Medicine of Dokuz Eylul University in Turkey. She worked at the Institute of Psychiatry, Psychology, and Neuroscience at King's College London as a postdoctoral researcher from 2015 to 2020, focusing on neuroimaging techniques in clinical trials and translational psychiatry. She became an academic clinical lecturer in general adult psychiatry at King's College in 2020, awarded consultant degree in general adult psychiatry in the UK with endorsements in Liaison and Addiction Psychiatry in 2023. Since October 2023, she has been working at the Experimental Therapeutics and Pathophysiology branch of the National Institute of Mental Health in Bethesda, Maryland, focusing on novel therapeutics, translational neurobiology, and multi-modal neuroimaging and bipolar disorder. And we've had to wait because of other things in the world to get this program going. This was originally suggested by our current medical advisor, Dr. Carlos Cerati. I think Dr. Yalin works in or with or under him. And so we're fortunate to be able to have some excellent top-ranking people. So I will turn this over to Dr. Yalin for, an hour or so as she chooses. At the end, we'll throw it open to questions or comments. I seem to have a lot of beeping, but I will mute myself as soon as I end this, and others may wish to do so as well. So Dr. Yalin will have the floor uninterrupted. I guess people can, is this a correct statement, can put questions or reactions in the chat as well as we'll ask at the end if people have such. So if everything's okay, if there are no other issues or concern, let me thank you and let me turn it over to Dr. Yalin.
Thank you so much for the very warm introduction and welcome. And thanks for having me in here. I do really hope that this presentation would be helpful in your lives to just to understand the concept of this in bipolar disorder. I'm thinking that if any of you is just suffering from this, possibly is just the problem better than me in the case. So I always think that patients are more knowledgeable about the difficulties of the disorder more than professionals really. So now what we are gonna cover today would be what is the importance of it, why we are today talking about this, and what would be the implications of these specific substances. I just picked 4 I mean, you know that like this is a very wide topic. I can't just like cover each and every of them, but like I try to pick the ones that like which are the most prevalent in bipolar disorder, and then we will be just like moving to the treatment options and how we can just like tackle with this. And for the treatment, I would be specifically focusing on the pharmacology techniques, like pharmacological treatments, not the psychosocial treatments. But just to let you know that like psychosocial treatments and the psychotherapies are the cornerstone in any alcohol or substance use. Without it, we can't just like go anywhere. So yes, we are using pharmaceuticals and that they are effective, but the cornerstone and the main thing would be always kind of like psychotherapy, and the psychosocial support needs to be there. So let's move on. Why we are today talking about this? Like, I think like the very first question is, how common is this in bipolar disorder? Now, the numbers are really high. As you can see, for the alcohol, it's like 3 out of 10 people would be at any time in their lives in bipolar disorder would be suffering from alcohol use disorder. And when I'm saying like alcohol use disorder, we are talking about the disorder itself. Like it's not like a simple alcohol or occasional alcohol use or even just like a risky drinking. So it is kind of like diagnosis. And when this is happening, like a 30% of the bipolars, thinking that like looking at the general population is 5%. So that gives you the pretty much the gap in between. Coming to the cannabis, it's 1 in 5 people with bipolar disorder would have the cannabis use disorder, and that is only the 2 to 7 in the general population. So there is, and again, a real big gap in there. Another one, which is the possibly the highest prevalence among the substances, is tobacco. I don't think that like that is pretty much specific to bipolar disorder, because like in every serious mental illness we have this tobacco problem. Unfortunately, a lot of our patients are like using it. Some of it is just like trying to tackle with the cognitive difficulties that like our medications are causing with tobacco. So I mean, we can just like talk about like a lot of reasons like why it is there, like why it's this high. And also, of course, just like any kind of like mania or depression or like all that like episodes would basically like push you towards to a substance. And the tobacco, I guess, just like being a kind of like an airbag in the day-to-day life of the any person with a serious mental illness. This is why this is the high. And the fourth one is the cocaine. That is also pretty high. As you can see, it's like in 1 in 10 to 15 people with bipolar disorder will have the cocaine use disorder, and it's only 0.4 actually in the general population. So you are in here in the graphic, you are seeing like all of them in one go. The substance use disorder in here is just like it's the all together, alcohol and the drugs. And the second one is the alcohol use disorder, as it coming in the second rank. And then the drug use disorder, this is just like including all of the drugs. So when you see that like alcohol is going for the first, and then you're in here just like moving to the cannabis, and then the cocaine is as the third rank. The tobacco is not in this per se specific study that like they conducted, but this is the biggest study ever conducted in this population and giving us the rates of like all of these. So obviously it's common, but the reason why it is common is just like it is a very, I mean, it's these are very related disorders to each other. First things first, the underlying risk factors are pretty much like very overlapping for the alcohol or substance use disorders and the bipolar disorders. So uh, there are a lot of like genetic markers and vulnerabilities that like bipolar disorder patients and addiction patients have. And these are all overlapping. So when you have one, the other is also just like coming together with it. And the second one is the neurobiological mechanisms. Like this is also like perfectly overlapping. Specifically, I mean, most of you by this time point possibly know that like there are neurotransmitters in our brain, and the dopamine is one of them. And the dopamine is kind of like a main neurotransmitter, which is just like a which is regulating the reward in our brain, and which is basically the again, the center of the addiction. Like any dopamine dysregulation would be just like going through all the steps, and it can end up with addiction problems. And actually, dopamine dysfunction is also an underlying factor on top on in the bipolar. So these kind of like neurotransmitter mechanisms are also just like overlapping a lot between the bipolar and the addiction disorders. That's why we are just like seeing together both of them. And the environmental factors. When I'm saying environmental factors, I'm talking about like life stressors and early childhood traumas and that sort of stuff that like that we are having like in life. These are both causing like or contributing both the start of the bipolar disorder. They are risk factors for that, and also risk factors for the addiction. So obviously, when you have all these common risk factors, I mean, that is just like so normal to have this kind of high comorbidity in between. And the second is obviously just like you would, I think like it would be pretty clear for you, like mental illness in itself will contribute to start the substance use and addiction. I mean, just simple examples would be like in a manic or hypomanic episode, there will be more impulsivity, more just like being hyper, and that comes with the risk of just like doing adventurous things. This includes also substance use and also just like alcohol use, and everything will just like go up. Then again, depression is another risk, obviously. When you are depressed, then you might any substance can serve to the different things that like to different symptoms that like a person is suffering. So let's say sleep problems during the depression, then it can just like a link to the cannabis use very quickly, and or alcohol for sleep, because if a person is not sleeping, then alcohol could be just like a helper in there. And then again, to get a kick from the depression, out of the depression, stimulants could be a good option. So these are also just like why how it happens is just like the symptoms of the mental illness basically drives the our patients to just like have this kind of like addiction problems. Coming to the third one, obviously, it's not only the one-way road. The second is also true. When you use substances, then it can end up with the mental disorder, which is bipolar disorder. It's where some of it, I mean, right now, like I will just come to that, like, but like, a lot of the substances at the moment have like we have it's proven to cause manic episodes, psychosis. Specifically the cannabis is just like going at the top of the rank at the moment, like and which I'm going to stress a lot because cannabis is becoming more and more legal everywhere. But we will be talking the risks related to the cannabis later on. And I'm just like I really want to highlight that is just like a cannabis is not something advisable specifically in bipolar disorder. because it directly causes psychosis and mania. This is a proven, like a fact. Um, Now, so as you can see, everything is just like a coming in together, and this is why we are just like a saying all these things, all these prevalences, just like this is why this is that common. And so in a just like a let's just like look at like more generally, what could be the consequences of this comorbidity? Why we are, I mean, it's not only hard for the patient, but it's also hard for the clinician because it is very hard to treat. First things first, uh, even the early onset of the disease. If a person is using substance, it's so hard to call it as bipolar, to just like differentiate how much of the symptoms is related with the substance used or how much of it is related with the actual bipolar disorder is always problematic. And this comes with the diagnostic problems and no treatment or treatment delay. Now, how it happens is just like this is very unfair of the system that like we are living in. And I'm still seeing this in a lot of settings. A lot of the psychiatrists are just like claiming for a patient to stop whatever the substances that they are using for the psychiatric assessments, which is technically not always possible. Or let me tell you something like this, it is pretty much impossible. So what needs to be done is just like the assessment needs to go hand in hand, and these are not something that like you can ask from a patient, okay, just like stop this substance so that I can diagnose you. That is not how it works. So, but then again, so having said that, it is hard. Despite you follow up the patient, sometimes it's just like you can't diagnose clearly and there will be treatment delays. Now, in a lot of the cases with the substance use, we are seeing earlier onset of the illness. Think it about like a scratching a wound. Okay, so when it is just like it is there, nothing is happening, but you scratch a lot, and it becomes like it bleeds. So this is what the substances are doing technically. What they are basically just like opening up the box that's already there with the genetic vulnerabilities and everything. So it's just like giving a little bit of a push, which is coming with the earlier onset of the illness. Obviously, psychosocial problems are there, like, and the social support is becoming decreased. But the more importantly, whatever related with the bipolar illness will be worse when we have this comorbidity. So the response to treatment will just like be lower than expected. And there will be more relapses to both sides, manic and depression. So that is just like not one way around. And the bipolar progression will be accelerated because of the substance use. And this is, uh, I want to stress this one, there will be more cognitive symptoms. So, as you all know, day-to-day life, possibly you are already just like a suffering from some sort of cognitive impairment, at least some of you. And if there is a substance use in there or alcohol, that cognitive impairment will just like be more pronounced. Um, and that is one thing like that would affect the day-to-day life. And the second thing is there would be increased risk for suicide attempts and suicide, which we don't want. And this is most likely is generally happening because any of the substances are increasing the impulsivity and giving you the that kick that like to go to the other side and to do it. So and obviously there will be also more, it comes with the more physical illnesses. Now, that is also another stress point. Bipolar disorder in itself already just like making a person vulnerable to a lot of physical diseases. Uh, I'm telling this just like it's not because of the medications. It's not just because being bipolar, just bipolar disorder itself is increasing the risk. Now, on top of that, when you add on the medications already that you are taking, and then add on substances or alcohol, then the somatic comorbidities, the physical illnesses are just like a booming after that. Like it would be just like a more and more higher. So this is just like a general what happens when you have like it did what I'm saying is just like I'm not talking about like one single substance or alcohol in here, but like that is more or less it's just like applicable all of these to any substance really. Now, but not every use is a problem. So how we are going to understand uh, what is just like more than a use? So this is how we are just like diagnosing. So again, again, I'm saying it may be so not every use is a use disorder. I want to stress this because uh, I know that like at some point the patient relatives of our patients are very keen to call it as addiction. Not every use is an addiction, and a person, a bipolar, a person with a bipolar disorder has also his or her rights to live their life as they wish. So you can't just like, limit everything in a life. So, yes, there are alarming symptoms, but not everything is a use disorder. Now, one thing, so we have like a four different blocks in here, as you can see. One is the losing control. So if you are losing control on your use, then that is one red flag. So how what we are saying is just like using more than you planned. Like you are basically just like you sit down for one and you are just like drinking the whole bar, then it is a losing control, obviously. You try to cut down, but you can't. And you have cravings or urges to get it. So these are the three signs of like losing a control on a substance. So by the way, this criteria is the same for alcohol or any substance. So it's kind of like that's the second one is spending lots of time around it, getting, using, recovering. So you need to just like think about it is not only the time that like you are using, it's also the time of the withdrawal symptoms. So starting from the time that like you started using and the withdrawal. So it needs to just like take a bigger time than the normal things. And if you give up hobbies or family time or anything in your life that is also important in this, just like for to use it, then that's also another red flag. Now, third one, the harm happens, but the use continues. So a person, I think like this is the time that like that is really the time that a condition needs to be seen if this is happening. So this is the first step. So the losing control and spending lots of time around it, it's still okay, like borderline, let's say. But if harm happens, but the use continues, then that is important. Your clinician, your psychiatrist needs to know about this. So problems at work, school, home, these are important. If you use in unsafe situations, like you use it and you then drive, or you do things that like you shouldn't be doing under the influence of any substance. And if you have relationship problems or your health or mood is getting worse, but like you don't stop using. So this is the time that you definitely just like disclose this to your clinician, do your use, or just like tell and talk around this. The four, if there is a body dependence, I mean that's the last point. I think like way before that, like your psychiatrist needs to know about the consumption of any use. So if the tolerance and withdrawal is there, that is, I mean, if it comes to there, possibly just like you already ticked a lot of the boxes before. So if one of is there, I can tell you that like it is a possibly alcohol and substance use disorder. It's not. It's not a maybe after. So these needs to be happen in a 1 year time, two or more. So as you can see, it's not very hard to get it, but context is important. So now let's just like talk about like what's the alcohol, what's the normal of this? Because like it's in one in three bipolar disorder patients just will be using it. So now US guidelines was saying women should drink 1 drink or less, and the man should drink 2 drink or less. When we say 1 drink, 2 drink, it is unit. So I also just like to put in here how to calculate the number of alcohol units according to milliliter and oz. So what is important in here is just like the volume and the absolute alcohol volume in it. So in every alcohol, you would see that like if it's 5% in the beers, like a 4.2, 4.3, or in the wine, it would be like a 12. There are also apps for this, so you can just like easily say that like, okay, this is what I'm drinking, what is the unit of it, and it will give you. But for a general understanding, these are the things that we call as 1 unit in here. And now, having said that, the dietary guidelines in the United States just changed a few days ago. Possibly you saw the news. Now it changed to the point of like no amount is a safe amount. So this was also the World Health Organization statement back in the 2023. Now US is also just like following the same. So um, no amount is a safe amount is where we stand at the moment. But this doesn't mean that like you know oh my God, just like stay away. If you want to drink, you will drink. So, but I'm just like telling you that like, these are the, advisable amounts. So now, and another thing is we always just like keep the bar really low about addiction disorders. So, um, because we really want to just like detect anything at the very beginning. So this is why the bar would be always very low, like so that you can exceed very quickly. So do not get stressed around just like these small numbers. Like if you pass it like a couple of days, that is okay also. Just like the stress also causes a lot problems in the bipolar. So it's kind of like balance. uh, so when there is a problem, if 4 or more drinks on any day or 8 or more per week, that is a heavy drinking for women. And men is 5 or more drinks on one day or 15 or more per week. So if this is happening, these are heavy drinking, and we don't want that because that is again just like going to the borderline, and it might just like well be just pushed into the use disorder at any time point. Now, high intensity drinking is basically at this time point possibly would get the alcohol use disorder diagnosis very close. So 2 or more times the heavy drinking numbers. Um, so I think like keeping it under the heavy drinking needs to be the aim. Let's just like put it like that. Now, how it affects bipolar disorder, obviously, just like we talked about, like an umbrella effect of all the substances, but like the facts. So when I'm saying the facts, it is like these are proven by the meta-analysis right now. Like we know that like this is happening when there is alcohol use disorder in bipolar disorder. Now, are there differences between sexes? this is a little bit concerning. Actually, since I read this, it's kind of like I'm a little bit more alert about this, because it was always the men using more than women. Like this is kind of like this is the same in the general population, same for the most of the substances, but possibly the first time in a meta-analysis I saw this. Now there is no difference between men and women when it comes to the bipolar disorder and alcohol use disorder. So they are pretty much using like head to head right now the alcohol, which means that we really need to just like because sometimes maybe as psychiatrists or as women maybe not always disclose their alcohol use disorder, or we don't always just like ask it. But the thing is just like the prevalence is pretty much the same between sexes. Now the likelihood of having both conditions generally declines with age. That's good news. The when you're getting older, it's just like I know it seems like the people are decreasing their alcohol use. Another question would be like if bipolar 1 or 2 is different, or if it affects the age of onset of bipolar itself. No, bipolar 1 and 2 are pretty much very similar. Like this would come again and again. For most of the substances, it is similar, like there's no difference. So now, does it increase the risk of other addictions? As a fact, we know that like it increases smoking and nicotine use, but I again just like will give an umbrella fact in here. If there is one addiction, there will be others. So none of the addictions are coming on their own. Generally, they come as a package. Well, you start with one and then you move to one. For instance, alcohol and the nicotine is one package, but we will just like continue with the other ones, like cannabis and also smoking. Nicotine is also another package. So, is it related with suicidal behavior? Yes. Um, the alcohol use, if you have an alcohol use disorder, it's more likely that like you have more suicide attempts in life. So these are the facts that like we do know. Now, okay, this is bad. It is bad, but like, oh, sorry, it's kind of like going on. Okay, now, is there a treatment? So this part is the good news. Yes. I mean, I told you that like psychosocial interventions is the most important, but then again, for the alcohol use disorder, we also have really good medications. Now, I put in an NT in here. It means the number need to treat. So what it means is, let's say we need to treat 18 people, for instance, for the naltrexone in here to get one successful patient. Now, when it goes down, number need to treat statistically, it means that like the medication is stronger and the more efficient, and the benefits are higher. Now, what's the importance of this is let's just like look at I just like put it in here. It's too small, but like it's kind of like I put it just as an example. What is the number need to treat for, let's say, very known medications? Aspirin for the prevention of the cardiovascular disease. Number need to treat is 50, 50. So I would say like our chances to stop alcohol use disorder with these medications are pretty good. So let's say antihypertensive medications to prevent stroke, it's 67. So as you can see, the well-known medications for other physical diseases, their number need to treat are way more higher than alcohol use disorder treatments. So naltrexone is pretty good. And that would be my first choice always as a clinician in bipolar disorder. So these are so it helps to reduce the chance of returning to any drinking and the heavy drinking. Uh, I know that like everybody generally just like which is a very, very fair question. What's the side effects? generally the most common side effect with the naltrexone would be the nausea and vomiting, and that is where the people are just like having the difficulties. But apart from that, it's only one pill, 50 milligram, you're taking it, that's it. Now, coming to the acomproside, it is also very good. As you can see, to any drinking, it is, and then number need to treat is even lower than the naltrexone because it's 18 and the acomproside is better. But about heavy drinking, which is just like binge drinking, is generally just like as a package in bipolar disorder. That's why I'm just like favoring the naltrexone more, because acomproside doesn't have a lot benefit in the reducing the heavy drinking. With the acomproside, the common side effects are diarrhea, and that is 6 pills. That is also the people are having a lot of problems because you need to just like take more, or you're already taking a lot of pills for the bipolar disorder itself, so nobody wants to just like, go on with the others. Now, again, if this didn't work, there's topiramate and baclofen, but we are just like using them. I mean, there's an evidence is there, and it helps, but they don't have as much evidence as naltrexone and acomproside for the alcohol use disorder. Now, come, one thing that like I always say, it is very hard to say to a patient who is suffering from a depressive episode at the time to stop alcohol. Stop it. So that is just like making your depression worse. Stop it. It's very easy to say, but it's not very easy to do. So we need to understand the fact that like that is not always possible or feasible. So there comes the controlled drinking. Is it a possibility? And recently, I would say maybe in the last 10, 15 years, like the approach is changing a little bit from the total abstinence to, non-abstinent treatments, just like, moderate drinking, reducing drinking. It was kind of a no-no before, but no, the evidence is there and it works. With the psychotherapy support, actually, controlled drinking is an option. So what I'm saying is you can also just like control your drinking with the psychotherapy support, and you don't need to go totally, sober or non-abstinent. Okay, I mean there are non-abstinent options that to just like to think. You don't need to go totally cold turkey and to be abstinent, and it works. If we go to that pathway, alcohol reduction, and then are there medications? Now, none of the medications that I'm gonna say in here is just like a licensed for this indication in US. But nalmefene is something that like we have been using in UK or in European Union for a long time. It is here, but it needs to be off-label prescribed, but you can ask, and it's the good one. So it's one medication, and what you do is just like you don't use it every day. You use it before going out, before the day that like you plan to go out and drink, or if there is like a drinking occasion, and then it reduces the intake, and it really works well. The topiramate is another one. And the baclofen also, just like these three, could be used for the alcohol reduction pharmacotherapy if a patient is just like can't be abstinent at that time and just goes for the controlled drinking option. So as you can see, there are a lot of things that like we can do about alcohol use disorder, and the only thing is just like what we need is you coming to us and telling if there is a problem and if you want help about it. Now, in the context of the bipolar disorder, you might ask that like, are there any like a proof if these medications are working in the bipolar disorder in this population? So as you can see, there are then and there a few studies. We don't have like big, but a composite was shown to reduce alcohol problem severity. There are two studies on naltrexone, and actually naltrexone, as you can see, shown to reduce cravings, increased abstinence, increased non-drinking days, reduced heavy drinkings, and one more, improving the manic symptoms. So that is also just like, well, I will take it. Like a medication is just like doing two things is always better than doing just like one thing. So this is why my choice, my personal choice, again, this is not something that like, my personal choice would be just like going to naltrexone first in the case of the bipolar disorder. Now, I know that like you hate using a lot of medications. That is very fair. And one could ask that, like, are there any medications that I'm already using that could be, beneficial to something, or just like, we can uh, hit both things just like together. So valproate could be an option. Valproate was shown to reduce also just like heavy drinking days and increase the time to heavy drinking relapse. So what could be just like if you, the mood stabilizer change could be an option in here, that like so you don't increase the number of medications. But with valproate, it might not be suitable um, for the young ladies, because like it affects the pregnancy, and it causes neurodevelopmental disorders in the child. So generally we can't just like give reproductive in the reproductive age. But then again, this could be also just like open to discussion with your clinician. Quetiapine was tried, no evidence. So unfortunately, I know that like possibly a lot of you just like using quetiapine, but it is not affecting alcohol use. Now, coming to the cannabis, one thing that like I really want to stress, as you can see, I thought that like there might be just like a maybe relatives, or like your child might be bipolar, and these are the different names that they can call cannabis, which you might not know. This is the street names. And it can just like be spliffs, bongs, edibles, vaping. So for every substance, there are different ways to take it. And I would always say, like, do not underestimate the creativity of an addict. They will always find a way to take something, and that would be pretty creative, actually. So the cannabis effects would be like in 1, 2 minutes, and the peak effect would last just 2 to 4 hours. And then, but in the urine test, it will be detectable in a month, up to a month. Now, um, this is pretty important now that like a cannabis is kind of like reachable everywhere. There are different types of cannabis, and the potency is important in a way that like the more potent versions will cause more severe symptoms when it comes to the psychosis or mania. Or if weed is the in I mean the most okay option among this, but skunk, for instance, or dab or shatter, they're highly concentrated cannabis. So with these ones, it is kind of like you are increasing the risk to trigger something. I mean, for the cannabis, I'm always saying that no is no, but like if you are gonna use, at least just like try to avoid skunk and the dab shatter on this case. And I just like put in here like how to understand what is what. And the pictures are in here so that like you can just like get the idea of it, but I'm not gonna go into that. So for the facts, what we do know, are there differences between sexes? That okay, in this case, yes, men with bipolar disorder are more likely. Bipolar subtype, again, no. I told you that's kind of like a blanket. There's no difference. Uh, does it affect the age of onset? Now, as you can see in here, that is what I was just like trying to say at the beginning. Most recent findings suggest when there is a cannabis use disorder, comorbidity, generally there is also like earlier age of onset of BD. Now, you can say that like, is it happening because the bipolar started early, or bipolar started early because of the cannabis is a question for us to study and look at in the longitudinal studies. We don't know yet, but there's definitely something there. And now, clinical characteristics like so they will be younger, possibly single, and cannabis use disorder is very related to lifetime psychotic symptoms, suicide attempts, and tobacco, alcohol, and the psychoactive substance use. Again, this is a blanket. When there's one, there will be others. This is again I specifically put this in here because this is CanMat that is kind of like the bipolar guidelines of the CanMat is something that like we generally as the bipolar disorder specialists just follow all around the world. It's kind of like a worldwide because it is the international disorder of bipolar disorder link there is with CanMat. These are the Canadian task force ones, but it also just comes from the International Society for Bipolar Disorders. So, in their task force report back in the 2023, they are saying that like there is moderate certainty of evidence that is actually just like quite high. Um, it says moderate, but like strand of recommendation is really strong with the individuals of bipolar disorder should avoid the use of cannabis. Look, we are not saying this for the alcohol, but we are saying this for the cannabis because cannabis will increase the severity of any episode that like you're going into, and it will also increase the psychotic symptoms on top of that. And there will be increased suicidality and the decreased functioning. So, and some of these things, um, specifically decreased functioning and the cognitive impairment, might not return back after some time. So, strong recommendation of do not use cannabis. Now, coming to the treatment, there gets things a little bit tangled because we don't have anything that is licensed for the cannabis use disorder. Now, uh, this is one meta-analysis. As you can see, again, the topiramate in here, Nabilon, and the fatty acid amyl hydroxylase inhibitors, but like they are totally experimental again. The Nabilon is in the market as it's an antiemetic. It's the cancer patients are using it, chemotherapy patients for the nausea normally, and it just like goes to the cannabinoid receptors 1 and 2. And that seems to be effective. Dronabinol, same, like with the Nabilon. They are just like pretty much sister, brother, sister, let's say siblings. And it is also an antiemetic. So that can be tried off license. But there is no, I mean, again, like these are all off label, like there's no indication for this, but like seems like there is some evidence, let's say. Gabapentin was found to reduce the cannabis cravings, and but there's no pharmacotherapy that improved the cannabis use severity, abstinence, or cannabis withdrawal symptoms, unfortunately. Now, the second one, this is actually a pretty new one. This Cochrane meta-analysis. Like I couldn't. They didn't publish the whole details, but like I could access the abstract only. They will be publishing it later in 2026. They just like made the statement. So as you can see, it's kind of like doubled the number of people in here with more randomized control trials. Actually, they are saying like most of these medications, again, the antiemetics is the THC-based medicines. So these are nabilon and dronabinol. They are antiemetic, but they are also, we can call them like THC-based medicines. They are synthetic THCs. Let's put it like that. So they are also psychoactive. CBD, NAC, oxytocin, or this FAAH inhibitor, nothing is working. Again, none of these may help the people to complete treatment. So again, I'm saying for the cannabis use disorder, we don't have a lot of options, and the risk is really high. So I would say that like we need to just like stay really away, and it's becoming widely available, and that is quite concerning, especially for the bipolar disorder group. Now, let's move to the cocaine. I will just like go, I mean, it's kind of like you can snort it, smoke it, inject it, and sorry. It lasts 20, 30 minutes, and then like smoking crack is even shorter. You will just like get the kick in 10 minutes, and it will be detected up to 3 days. And it will be normal cocaine that you see is the white powder, but nowadays mostly it is the crack because it's more prevalent. Cocaine is more expensive, so people are going crack, and actually crack is a little bit just more problematic than the cocaine. So it will be small lumps and rocks that you will see, and these are the names. Now, for the cocaine, actually, we have very, very little information, really, like how it affects the clinical presentation of the patients, which we asked ourselves. And this is the one study that like I did back when I was in the UK. We looked at the bipolar disorder and cocaine use disorder comorbidity and what is happening in there. So our very first question was like a cocaine might be just a causing the bipolar, maybe like it starts first and then after. But actually, 60% of our patients were diagnosed with bipolar before the cocaine comes. And but there is also like with like 20% of them like with the first diagnosed with cocaine use disorder, and then the bipolar comes after that. And there is also like a 15% of them like they're starting at the same time. Female, male, again, even like alcohol. Now, I think that explains pretty much everything. As you can see, comorbid alcohol, comorbid cannabinoid use disorder, like this is just like going. These are the risks. Like the highest risk is the alcohol. Do not forget this. Cocaine is never the primary never the primary substance. It is always like a secondary or tertiary. So if cocaine is already there, there must be something else. So it never comes alone. I mean, none of them are coming alone, but like for the cocaine, for sure, never comes alone. So as you can see in here, like we also found the like a higher comorbid rates with the other addiction disorders and the treatment non-adherence, and there was just comorbid sorry, axis 1 and 2 disorders were really high, and the age of onset was earlier on. And the other social factors were also just like really there, like forensic history, history of violence, history of sex work, lifetime housing difficulties, or child care difficulties, problems. So all of them were higher in the ones that like who was using cocaine. And two other, I mean, that I do know of apart from ours, there are three other published articles which found pretty much the same like us. Now, how can we treat the cocaine user? Well, I mean, that is also another one that is just like we don't have a lot of options around that. As you can see, everything is just like low certainty. And when I'm saying low certainty, there like this is for the general population. It's not even, I'm not coming to the bipolar. Like normally in the alcohol, I told you that like, okay, we tried these medications also in the bipolar population. Cannabis, nothing in the bipolar, as you saw, like nothing in the general population is working even. Now, cocaine, it is even just like, these are then and there, not a lot of even studies there. So, but options are bupropion, topiramate, modafinil, topiramate plus mixed amphetamine salts, or long-acting amphetamines might help. These are just like only this one, topiramate and long-acting mixed amphetamine salts are moderate certain, the others are low. And there is another meta-analysis saying no pharmacotherapy actually just like better than placebo, but contingency management, like a behavioral intervention, is the only one that's working in the cocaine use disorder. Um, there are two studies that specifically looked at to treat the cocaine use disorder in bipolar. One used cytocholin and one used cytocholin and the other used lamotrigine. With the cytocholin is just like didn't work out, nothing on the cocaine outcomes, but with lamotrigine, there was significant reduction, marginally though, in the money spent on the cocaine. Now, in here, I talked a lot about some psychostimulants, as you can see, amphetamines, long-acting amphetamines. Bupropion is also like has some like a dopaminergic. So you might think that like what is the psychostimulants are causing, like how we are going to use this? Maybe there might be a manic switch. So I thought that like that might be the question, but latest meta-analysis is saying that like if prescribed psychostimulants are not causing manic switch, but still there needs to be a mood stabilizer there, and it needs to be under a clinician and with the close follow-up. Coming to the tobacco, that is the last two slides. Strongest evidence are for the nicotine e-cigarettes, obviously. Then varenicline is the third one, citizen, and a combination of these three with the nicotine replacement therapy. So this is for the whole general population, again, the treatments. Also effective again, bupropion is coming in here, which is also another medication we also use bipolar disorder in bipolar disorder time to time. And there's just like a may help ones, but I think like for the tobacco use disorder, we have quite a bit of options. Now, one thing about obviously just the strongest evidence is for the nicotine e-cigarettes, but like I would like to just like remind you one thing, because that happens a lot. That's just like something that I'm seeing. Now, we are starting these e-cigarettes for the, to stop smoking, so smoking cessation. And then what happens is the people are stop smoking, but people are becoming addicted to the e-cigarettes, thinking that like e-cigarettes are kind of like a better option than the cigarettes, less harmful. And at some point, a lot of patients just going on and on and on with the e-cigarettes, just like, using it like normal cigarettes. And they time to time also add on normal cigarettes. Then things are getting like really tangled. Now, the latest, one of it's 2024 publication says like, actually it is same. Like e-cigarettes and the cigarettes are pretty much doing the same harm in terms of cardiovascular disease, stroke, and the metabolic dysfunction. E-cigarettes are not the safer option. They can be used only for a limited time frame. Then you need to stop. And if you think that like there might be a dual use, then the risk is just like really increasing, and that needs to be avoided. And if you feel like that might be the case for you, then I would say that like do not go for the e-cigarettes, go for the other options like medications. Varenicline actually just like trials in the bipolar populations, and it works really well, which is just like increase in nicotine abstinence, even just like by 3 months. So I would say varenicline would be the first option. Bupropion was also trial, no clear benefit, but still in the case that like if the others are failed, I would still use it, but again, with a mood stabilizer because bupropion is an antidepressant, and due to risk of manic switch, we always just like a combine antidepressant and the mood stabilizer. And but one thing, bupropion is actually just among the safer antidepressants in terms of hypomanic manic switch. So I think it can be easily trialed. So that would be my last slide. Thank you very much. I'm so sorry. It was a little bit just like long, I think, but yeah, the topic is also extensive. But I'm happy to take the questions.
Thank you, Dr. Yalin. And the host, oh, okay. I don't see any message questions or messages in chat. Are there questions? I think people can speak up and ask them if you'd rather put something in chat. I see a thank you in chat from Megan.
Hi, thank you so
Yeah.
much. I have a question, if that's okay.
Yes, sure.
When you were talking about the when you were doing the alcohol portion,
Yeah.
and you spoke about how in a year's like the span of a year, if you've done two or more things, then you should consider an addiction.
Mm-hmm.
What if you only drink when you're in a manic episode and like you have no desire to drink when you're not?
Yes. So, okay, that is a totally different concept. So that is not going to go under the alcohol use disorder, first things first, because whatever is happening, possibly is happening. If you are saying if there's a clear cut, you are going to manic episode first, and then alcohol use, like the increased alcohol use follows, then that is related to manic episode. That is not an alcohol use disorder. When the manic we just like treat manic episode and the alcohol problems are just like gonna go away. But if it stays beyond the manic episode, or if it starts like before it, like if it's still there, then that changes. So but if it's strictly in the manic episode, that doesn't need a treatment. Just the manic episode treatment would be enough.
Great. Thank you so much for explaining the difference.
Okay. Did I see an electronic hand from Shri?
No, I didn't have a
I'm
question.
sorry. Jake, were you waving a hand? Jake, you're on mute. Jake, are you trying to unmute or am I misinterpreting?
I'm there. I tried to send a chat to Dr. Yalin. Did you receive it?
Now I'm saying so that is by the same brain activity that causes bipolar.
Well, there are two parts. I ran out of room.
Oh, okay. So that I only got this one.
Ah, okay. Well, so I'm trying to get a concept of what causes alcohol abuse by someone who's bipolar, and often I believe it's explained that it's self-medication, which would be an attempt to deal with the symptoms of bipolar.
Yes.
But I wonder if it's perhaps a better way to look at it, or a possibility to look at it, as being caused by the same brain disorder that causes bipolar.
No, you are absolutely right. Like so the point being is just like every patient is a different world, and everybody's reason on using one medication is different. So not every person is just like using it as a self-medication. You are 100% right. Like it can be only, as you said, like neurobiological factors that is underlying in bipolar, also causing the alcohol. And to be fair, as an addiction psychiatrist, how I see addiction is just like bipolar. The people can relapse. That's normal. We just get them again back on the track. And then there will be an abstinence. They might again relapse, like manic episode, depressive episode. That is just like what you are saying exactly. So yes, it can be exactly seen like this as well. Not every alcohol use is self-medication. Sometimes it is not just like that in the people's sense. That is just like genetic vulnerabilities and the neurobiological mechanisms are already just like pushing you to use it. So this is why I'm just like stressing out. Do not blame yourself for anything, like in case it happens. Just sometimes it is just like seriously, it's not in your hands. Like how bipolar is not in your hands. These users are also not in your hands. This is exactly the same. I know that the people are framing it in a way that oh, you have kind of your own will, you can stop. Well, that is not how it works. We all do know that. I mean, I really hope that it might no, it's not like this. That is also another neurobiological illness. Not everybody is just becoming addict to something, right? So that is not only the willpower. There is something that makes these people to get addicted to these substances, which are just genetic vulnerabilities and the neurobiological mechanism dysfunctions.
Okay. Other questions or thoughts?
Kristen raising a hand, I'm saying.
Oh, Kristen, yes. Sorry, go ahead.
This is Kristen. I have actually a comment to reflect on about tobacco use. So you mentioned e-cigarettes as not necessarily being helpful. I was a smoker for something like 20 years. And when e-cigarettes first came on the market, I tried to use them to quit. And it was not helpful at all. I didn't even then become addicted to e-cigarettes. They weren't helpful. They were a poor second. But what I did do, and I don't believe in willpower as a concept for food or for addiction or for anything, but I did read this book called The Easy Way to Stop Smoking. I don't know if you've ever heard of it.
No, I didn't. But it's good to know. Yeah.
Yeah. So it's this book called The Easy Way to Stop Smoking, and it's basically a book that it's psychotherapy in a book, because it talks about how smoking is an addiction, and you don't quit, you stop. You're not giving anything up. So if you stop, you're no longer beholden to the addiction, and it allows you to keep smoking as you're reading. So you're not stressed about the idea of stopping. And then when you finish the book, you stop. And I actually did that like 15 years ago. I read the book.
Wonderful.
Yeah, I tried 3 times. The first 2 times I didn't finish the book because I didn't want to quit smoking. But then the third time, my bipolar was stable. And I was at a job that was stable and manageable, and I did, and I haven't had a cigarette since that night that I finished that book. So anyway,
that is just that. No, that is not easy. By the way, now that you said, I will add on one thing. Tobacco use obviously just it's not gonna just make detrimental effects on the bipolar disorder per se itself. But I think the problem is the side effects of it. I mean, what it causes, metabolic problems. And you got, I mean, most of the bipolar patients are already having metabolic problems. And the tobacco use just is coming as a cherry on the top. This is why, I mean, it's not because your bipolar is affected badly about tobacco use. It's more kind of trying to prevent the cardiovascular diseases and the hypertension that would be upcoming with the tobacco, because there's already increased risk with bipolar and the use medications for bipolar.
right. I do feel that stopping smoking improved my mental health
Oh,
because nicotine is agitating.
that's true.
Yeah,
It's
so it
true.
was a significant event. Anyway, I wanted to share that with you. The
Thank
Easy
you.
Way to Stop Smoking is a crazy book. It's wild. Yeah.
Ethan?
Hi. Well, I just first off, I just want to say thank you, Dr. Yalin, for this presentation. It was great, very informative. Also, really liked your kind of nuanced view on some of the things. There's a lot of clinicians that, will just say abstain from everything, period. If you even have like one, it's just really not practical.
No.
So appreciated that nuance there. But one thing I wanted to ask that you brought up earlier was you said that people with bipolar disorder are at a elevated risk for comorbidities, irrespective of any medication they may be taking.
Yes.
So I'm very well aware of the comorbidities that come with a lot of the medications used to treat the disorder, but what are the comorbidities that people are susceptible to um, outside of medication?
Uh, so cardiovascular diseases is the one. It is just like so the very first thought it was like a cardiovascular disease or stroke and any vascular related disease, if that makes
Hmm.
sense. We were thinking like it is possibly the medications that like we are giving, but no. Beyond the medications, there's already an increased risk for just being bipolar to get these diseases. So that is per one. And some of the cancers are also just like a particularly increased in bipolar. I mean, it is not like a high prevalence, but we do know that like compared to general population, it's not on top of my hand, but in the bipolars, some type of cancers are just like increased like 2 times or 3 times. That is just like going around that. And cardiovascular and the stroke is another one. And generally, like again, diabetes also is another one. We are thinking a little bit like for the cardiovascular and the diabetes, that like metabolic
Hmm.
package possibly is coming. Maybe they are both related with inflammation. Like bipolar, also there's an underlying problem about inflammation that we do know of, and metabolic as well. So there is again possibly some overlapping mechanisms there, which is just like causing the both. So not every time like the medications that like you are using as the culprit. So it might just like be the bipolar disorder risk itself. But then again, also disease is making us like some time to time like a sedentary
Hmm.
lifestyle. Um, sometimes we know that like they are not keeping like the bipolar patients are not known best for the exercise or like keeping
Hmm.
up with the good diet. That is also just like a maybe contributing. So these are just like three things: the treatments, sedentary lifestyle, and being bipolar itself, like with the overlapping mechanisms with this disorder. So it's kind of like a lot of elements coming together, really.
Yeah, that makes sense that it's really a multivariate when you think about it. I assume like the stress that often comes with bipolar disorder probably also compounds the cardiovascular effects as well.
Yeah, I mean, it is really hard to have a lifelong disease which starts early in life.
Hmm.
That's not easy to tackle, and that is not even like easy to accept at the very first place because most of the people are getting the diagnosis in the early 20s.
Correct.
And I think that like even just like a coming to terms with that fact is like dozens of stressful days and the tear and sweat and everything. So no, you are totally right. Like all these things are also just like obviously causing that. Like it's kind of like everything is just like cumulatively
Hmm.
going to the end, let's say.
Yeah, absolutely. Makes a lot of sense. Thank you very much.
Okay, there is a question in the chat from Stephanie. Let me read it. Is there evidence that of pharmacological or psychotherapeutic methods,
Uh,
one one works better than the other, or that they work better in tandem to treat AUD in BD?
Well, it is a great question. The best case, like if you're asking, I mean that this is my clinical opinion mostly. I think if we can just like combine the behavioral treatments, like psychotherapy, and on top and the pharmacological treatments, that is the best option, really. And if you go for the psychotherapy or the medication, it will, I mean, psychotherapy is always the kind of like a cornerstone, really, as I said to you at the very beginning. Like that I will always just like, I will say to you that like you need to have that anyways. But honestly, it's just like a possible, I would say like, I can't remember on the top of my head if there is like a head-to-head comparison of it. But I'm guessing like a psychotherapy is possibly would be more effective than the pharmacological treatments, maybe. Just about then again, like on what cases? Like, is it the abstinence that we are looking at? Is it heavy drinking that we are looking at? So there are a lot of like layers of that, like addiction. So it's always the best to just like use both if you can. And generally, it's just like the people also, it's very hard to reach to the therapy. So whenever you can, like then use both of them. I would say just like hit it hard.
Okay. Are there other questions, reactions, thoughts? I want to give everyone who wants a chance. Here's a comment. Judy enjoyed the presentation. Thank you. I think we all want to thank Dr. Yalin. I wanted to say something about upcoming programs, but did you want to say anything else, Dr. Yalin?
No, thank you very much for having me. And I hope that like it was beneficial somehow.
Thank you. Thank you for joining us. We're always glad we can do this. This program is being recorded, and it may take a week or so, but it'll be made available on our website with closed captions. So on our webpage, DBSA-NCA.org, there's I think a speaker programs page where various of our prior speakers may be seen, and this will be added to it. As I said, we are the National Capital Area Chapter. We have, I think, 10 different mood disorders support groups meeting. One regularly meets on Thursday evening, except when we have the speaker program, but we have 3 in person in DC, in Silver Spring, Maryland, and in out by Dulles Airport in Northern Virginia. And we have 7 virtual, one specifically for women, one specifically for LGBT, and new participants. Adults with mood disorders are always welcome, and full information is available on our website. And we are planning other speaker programs, including with our medical advisors support various leading researchers at NIMH, and we were looking to have the next one in March, I think, on the science of suicide. So that'll be on announced in groups and on the website. Also on the website, you can see our weekly newsletter, which you can get emailed by clicking on the thing, inviting you to give your email address, and it goes out each Sunday or Monday. So thank you all for attending. Thank you, Dr. Yalin, and we'll see one another again. Good night, everyone. And I will end the meeting.